So this is, as I say, a very common problem. Half of the people that we see, especially the ones who are not doing well, who come into hospital, for example, have both of these problems. And how does that play out? Well, for one thing, we know that if you are using substances, this really slows down your rate of recovery or prevents it entirely. So you may not get better from depression. You may have some relief of anxiety, but not entirely. You may never be able to get a real good recovery from psychosis. It just slows the whole process down. One of the really unfortunate things is many of the patients we see that are seriously ill have very little money. They're on ODSP, and the drugs and alcohol are very expensive and take up huge, and cigarettes, take up huge amounts of their financial wherewithal. So they don't have any money left over for good food, to try to do something for themselves in the way of even just something to occupy them, or some art, or even therapy or something. They have nothing left over because this is taking all of their money. It entails interactions with people that are not always the most desirable, and they're involved in illegal activities, and very often they are stealing or involved in crime to try to get enough money to get substances. We've mentioned already that psychosis can be brought out much earlier if people are using, especially marijuana, and the younger you develop a psychosis, the worse it is, the worse your prognosis. It's impacting you at a time that you're just a young person, you haven't finished high school. That's very different than a person who maybe is in college or is married or has other supports. It's a lot harder to get better. And you alienate the very people that you really need to help you with a chronic illness like this. So your family get furious at you and say, why are you doing this? And your friends get disgusted, and the only people that you're hanging out with are the people who are high all the time, and not necessarily the most motivating group of people. So something we talk a lot about with myself and my colleagues is, so maybe we shouldn't be dividing these two areas into two different kinds of illnesses. And the more we look at these illnesses, the more we see that they have more alike than they are different. Some of this is sort of a political, historical division. I think sometimes the stigma against mental illness makes the people who are using substances not want to be identified with mentally ill people, or sometimes it goes the other way. The mentally ill people don't want to be identified with the substance people. And sometimes people are worried that if they don't have a separate organization and their own funding, that they're going to get crowded out by the other people. So historically, these two things were divided. And the philosophies were perhaps quite different about treatment. But increasingly, we're finding that we're moving together, because we're finding we need to look at all of these approaches to try to get people better. I had a wonderful meeting last week with the people at Brentwood, and we're, for example, saying we really need to work together. They're recognizing that many of their clients have mental health needs, and so it was very gratifying, and I think that's a wonderful thing. We've found that you have to treat these illnesses together. It's no good to say, well, you go off over there across town to those people and get that dealt with, and when you're done, you come back over here and then we'll deal with the other thing. That just doesn't work. You need to deal with everything that's going on in a person's life, and you need to do it in one place. They're dealing with enough without having to go all over the place to try and get help. So we see substance abuse now as a much more biological phenomenon. We see that it has strong genetic component to it. We know that it has a strong effect in the psychology of people who use substances. So the way their psychology affects their judgment of risk, not only in using drugs, but in many other things. So this really becomes a cognitive illness, so that even if people aren't drinking, the way they think is different. AA, of course, has said that for years, and they're right. And we're beginning to find that there are medications that are helpful. So this is very exciting, because I think even, I went back and got training 10 years ago, and we weren't talking about it very much. And within 10 years, this area has exploded. So we now have 4 psychiatrists at Hotel Dieu that have a lot of expertise in this and know all about treating these illnesses with medication. And it's been wonderful for us. So we often will talk about that as to whether we should be seeing these things separately or how we should treat them or what's the best thing. And I think oftentimes it depends on the patient and how they see it themselves and what's going to work for them. So this new kind of concept of these problems has really changed the way we look at things, the way we approach things with the patient, and how we treat things. So we know that we need to treat, if you have both of these kinds of problems, we need to treat them together, hopefully in the same agency, the same staff. And we need programs that understand the medical end of things, the psychological end of things, the behavioral end of things, the spiritual end of things, the holistic approach, the whole person. I think we know that this is a lot more than willpower. If it were, nobody would use substances if they could just stop. That's there, but it's a lot more complex than that. And I think we're starting to look at the whole approach to this, which is legal. It's very exciting because in Windsor, we now have a mental health court. So people who have committed crimes, but they are doing so because they have a mental illness, are now diverted to that court, because we recognize now that to put those people in jail doesn't make any sense. They're not going to get the right treatment. They're much better served to be diverted into the mental health system. Similarly, we now have a drug court so that people can be diverted to drug court if they're stealing or involved with the legal system because of substance abuse. It's silly to lock them up. That's not going to do any good. They have to be treated. So that's very exciting. I had one line there about involuntary treatment. So one of the debates that we have on the ward is, are these the same sorts of illnesses like schizophrenia, for example? So we'll have patients that come in that are quite ill, don't really think of themselves as ill, don't really think they need any kind of treatment, but they're in pretty bad shape, and we're worried about them being vulnerable or hurting themselves, hurting other people. So, of course, you probably know, we can sign the paperwork to have them stay and also make the argument that they should be treated, even though they don't see it that way. And there's a lot of legal controls to that. We're not allowed to just do that. But sometimes we know this is what's going to be important. If we don't do this, this person really could get into terrible trouble or die. So we do that. So sometimes the argument comes, well, should we be doing this with people with substance abuse? I know we frequently have family members who would like us to do this. They bring their family member in and say, he's drinking himself to death. We're at our wits' end. Can't you just lock him up? Now, I wish it were that easy. I think one of the difficulties is that with psychosis or schizophrenia, we have a specific treatment that we can impose on people, and it may not be the best, but very often with treatment is successful, and then people will come around and recognize they have an illness, and and be able to continue on with treatment voluntarily. With substance abuse, it's a bit different. I think we've always felt that people sort of have to come to the realization on their own that they need help, and be ready to accept that. But we'll often see people who are so cognitively impaired from substances that they can't. Don't ask me now what we should do. I don't know, but we do talk about that quite a bit, and it's a big question. We could talk about that all night, I think. So, questions? Yes. A question is to define psychosis. My definition of psychosis is a person who has lost touch with reality. So what that could mean is a person who is, we use the phrase, responding to internal stimuli. That means that they are hearing voices, or they are seeing things, or they are feeling things touch them or something, and there's nothing there. So these are coming about because of abnormalities in the brain. They have abnormal kinds of thoughts we would call delusions. So they have very fixed ideas about things. There's Martians, there's the mafia, somebody's chasing me, somebody's taking pictures of me. There's pictures of me on the buses, people are talking about me on the street and so forth. You can see how that fits in with the other. And various other cognitive problems that where their reality is not the same as ours.
My second question ties into the first one.
Yes.
You said early use of medication, self-medication. Does that include ADD meds?
That's a very good question. So it depends. There's a lot to that. Yes. So I would think the first, if you're talking about kids being prescribed medication for ADHD, there is no evidence that they have higher rates of psychosis than anyone else. None. And that's been very reassuring, because there's a lot of fear among doctors, never mind everybody else, about stimulants. These are powerful drugs. They act in the brain. They can be habit forming under some conditions. We worried for a long time, would this promote substance use in young people, and would it cause other problems? Particularly when kids are young, they may have problems with concentration, focus, and behavior that look a lot like ADHD, but as time goes on, then they start to develop voices and they start to develop delusions, and you think, oh, you know what, that's interesting. What was going on there? Was that really ADHD and now there's something else, or was that an early presentation of psychosis? I think that's very hard to tell. I think there are definitely young people that look like ADHD when they're young. My personal experience, I haven't got a lot of good data for this, but my personal experience is they don't respond very well to stimulants, or they respond briefly, but not usually. So kids with ADHD respond to stimulants miraculously. It's like night and day. They go on and they're fabulous, right? These kids, they get some improvement, but they don't really respond all that well. Now, there's a lot of reasons for that, but one of them is, I think, as they get older, that they really have some other disorder, and we just have no way of determining it. There's no test, there's nothing at this point. Now, if you're asking me if people go out and grind up, or something, pills or Ritalin or something, and snort it, could you get psychotic? Yes, you can get a lot of symptoms of psychosis with that, but you don't get psychosis. You get symptoms that look like psychosis that go away when the stimulant gets out of your system, right? Can it bring on psychosis in somebody who's susceptible? Here's the interesting thing. People who get psychosis don't particularly like stimulants. It's not their drug of choice. Their drugs of choice are always marijuana and alcohol, almost virtually always. So that's it. What does that mean? I don't know. But it's interesting, isn't it? Yeah. Okay. Anybody else have any questions? I can't do all the work here. Come on. Yeah. Oh, yeah. And the most common way this happens is that the parents are separated. So they're with mom all week, who knows very well that they need medication and gives it to them every day. As one woman put it to me one day, if there's a fire, I take the kids, I take the medication, I run out the door. So they know. But then on the weekend they go to dad's, who likes to say, your mother doesn't know what she's talking about, that's a lot of hooey. Doesn't matter what it is she says. I think he usually says this. and he tells them that. He also lets them stay up till 1 o'clock in the morning and drink 50 bottles of Coca-Cola and I don't know what else. And so, and they come back kind of wound. So I've heard that story more than once. Yeah, it's difficult. But the hardest thing, though, is that the kid is getting two completely different messages, right? Which is very hard. Yeah. Yes. Yes. Absolutely true. Yes. Yes, that's absolutely true, and that's a very good point. So thanks for bringing that up. So we know that there are some kids that the benefits of the medication are really necessary in school, but not so much necessary at home. Now, I'll just say, as a well, I'll tell you, the biggest benefit to this medication, I believe, is not in schoolwork. The biggest benefit is for children to learn to get along with other kids. So the saddest thing that I see is kids whose parents have very they're very well-meaning, and they really don't want to give their children medication. But by the time they come back, and the kid is in 4th and 5th grade, they don't get along with anybody. The other kids find them annoying. They're very impulsive. They get mad and they hit other kids. It's the social skills that are lacking. That's the toughest thing. And you're going to need social skills on the weekend, too. Now, I know some kids who have mostly the inattentive type of ADHD, so they're not particularly hyperactive and impulsive, but they have trouble with the focus. They get along very well on the weekend without medication or all summer. And you're right. Sometimes this is a real problem. The biggest problem is the kids who really need the medication and don't gain weight. Thank God that's rare. We find kids don't eat during the day, but usually they'll make up at night. They'll make it up, but they should be gaining weight. And if they're not, you try everything. Try different types of medications. Try different things to try to offset that. Yeah, but yeah, sometimes it's a tough one. No questions. I guess you had to ask all the questions.
You mentioned social skills deficits very quickly.
Mm-hmm.
Are there any programs for children outside the school setting?
Not as many as I'd like. The Learning Disability Association of Windsor has some social skills training. But I think this is an area where it's interesting. In the last 10 years or so, people have become very interested in autism. And we know that there are many children who may not be meet criteria for autism, but they have terrific trouble with social skills. And one of the groups are kids who are very impulsive, because instead of stopping and thinking, is this going to hurt someone's feelings, or something, they just out it comes. So although medication helps with that, a lot of that is training, and a lot of it has to be done right at the point of action or interaction or whatever, and that's difficult to do. You can't take a course once a week, right? Because these kids won't remember it. It's got to be right in the moment, a teachable moment. That's right. And oftentimes someone has to intervene to sort of slow things down enough. So it's a tall order. I don't know how we're going to do that one. Yeah. Okay. Well, that's a good question. I find, I'm sure that happens, but what we find much more commonly is people take things that are sedating, marijuana or alcohol. And a lot of times that's because if they get sort of mellow enough and they can stand, sitting around with a bunch of people, that's a big motivation. Now, I don't understand that one either, but it's strange what people will do. I don't know why anybody really would want to have hallucinations, but there you go. I mean, ketamine is one of the biggest things going, and that's one of the things it does. I don't know. The vast majority of hallucinations are unpleasant, but occasionally we'll have people that they feel very comforted by hallucinations. The voices are a very positive thing in their life. That's a tough one, too. But that's the exception. It's almost always distressing. Well, maybe that's no more questions. That's good. Thank you for coming, I guess. Eat some more snacks.